Okay, here is the 2016 Next Step, Advanced Respiratory System, Chapter 9. Begins with exercise 9.1. This is a sore throat, strictly outpatient, so you determine your level of service, and then you have to have a diagnosis code to back that up. Easy as pie. 1B is going to be the throat culture that was done in office. So find that, and then you'll have your same diagnosis code. Not tough at all. Your case 9.2. This talks a little bit about having to use the Hicks-Picks modifier GC for the presence of a resident. You'll probably have at least one or only one question on the board regarding this, but this is how you would code it, and make sure you have that GC modifier to flag it that there was a resident involved on these notes. This is an admission and physical. This is an admission note, which is a history and physical into the hospital. So you'll need to determine your level of service, use your modifier, and there's several diagnosis codes here, and I think I ended up adding one, or maybe just one. I don't know, maybe I didn't. I think I did. There's the pneumonia. That's why they're going into the hospital, so that would always have to be sequenced first because that's the reason they're encountering healthcare. They've got the COPD, they have a respiratory failure. I think the anxiety is what I went on and added. And anxiety is not over here, but it's a chronic anxiety that would very much affect their breathing and how they're progressing and getting better. So I believe I added that chronic anxiety. So your answers won't have it. Doesn't really matter, yes or no. For the board, they're multiple choice anyway, so you would have it there or not. So it doesn't really matter. I'm just explaining why I coded it. This patient is also oxygen dependent, so I would code that as well. That is significant if they're on the ventilator. 2B, chest x-ray. I believe it's a one view. Your diagnosis codes are very straightforward there. 2C, this is another chest x-ray, same diagnosis codes. This chest x-ray ended up being a two view, I believe. 2D, this is a subsequent. Remember your three levels of subsequent inpatient. You either have getting better, which is the level 1, still having to work on stabilizing, or still changing your medical management angles, which is a level 2, or getting worse, which is a level 3. It's kind of how I think of them now. Obviously, there are some exceptions to that, but that's kind of how I think of them. Your diagnosis codes here, they come up with a specific pneumonia, which is the interstitial, so make sure you kind of tweak your diagnosis code for the more specific pneumonia. They also have a gram-positive bacterial infection, so there's going to be an A code for that. And then their COPD and their respiratory failure. 2E, this is about the same as 2D. The patient, they do state that they are oxygen dependent, so I would stick that Z code on for this one. 2F, this is just a level. Like all of these are, it does appear that they're getting better. They're back to just a regular kind of pneumonia. They say the interstitial has resolved or is clear now. So it appears in this one that they're getting back to their baseline. So that will kind of help you determine your level. And 2G is the discharge summary for pneumonia, chronic respiratory failure, and the COPD and oxygen dependent. That one wasn't too bad. Well, this whole chapter isn't too awful bad. 9.3. This is a admit into the hospital. No, it's an admit. I think it started out as a consultation and then they admitted him, I believe. without sitting here reading it completely again. So I believe that's what it is. This is one where I would have put a lot of extra diagnosis codes on here too. So from your perspective, stick to what's current and affecting care for the reason they're being put into the hospital. I would have added most of these POAs or in the past medical history, the POAs present on admissions, but you don't necessarily have to. This patient's being put in the hospital for the lung edema. They have the respiratory failure. They have diabetes. They have congestive heart failure. They're on a ventilator. I personally, because of the CHF, would add this cardiomyopathy. I would add the COPD because I think that directly affects the respiratory status. I don't know that the coronary artery disease with the previous CABG is 100% important, and I don't know that the old MI is. In the real world, you obviously would. But for this case, I just kind of listed the ones that I thought, so I would add 2 more here because the cardiomyopathy and the COPD directly affects the respiratory status here, especially since they have congestive heart failure. So this one, kind of easy peasy. They do have this elevated CK, creatinine kinase, that they've highlighted for you. Okay, 9.3b. They are in the hospital. Patients on the ventilator. They have the pulmonary edema, the respiratory failure. They do have a mild pulmonary hypertension. I believe they used a diagnosis code of cardiomyopathy, and nowhere in here could I find the words cardiomyopathy. So I kind of thought to myself, how are you guys going to be able to do this? I know in the real world that they've combined quite a bit of this cardiology review of systems. They don't think they're having an acute MI. They've got the mild pulmonary hypertension, and just in general, they say they have a really bad pump. So cardiomyopathy, apathy meaning disease, myo muscle, cardio, cardiac muscle. So cardiomyopathy, just in the word, means that there's a disease process going on with cardiac muscle, which obviously is what's going on. I kind of disagree from a learning standpoint that they would put cardiomyopathy on here. I think you have to stretch, and I'm teaching you guys to code what is evident. It's different when you get some experience and you're in the hospital, and if you were doing inpatient coding, for sure you might be able to come to a different conclusion. But for us right now, I personally would leave off the cardiomyopathy because I didn't find it in here. Now, if you guys find the words in here, code it. I didn't. They have an abnormal potassium. They've got an abnormal phosphorus, and then they're event dependent. 3C, this is a chest x-ray, one view. They're already intubated. You can see that they can see the endotracheal tube, so make sure you have your Z code on here. 3D, this is still a subsequent day. The patient remains unresponsive because they have him sedated. He has the pulmonary edema, same kind of thing. Here they do have the cardiomyopathy. 3E, he appears to be improving because they extubated him, so he's not on the ventilator anymore. So that would be a sign that they're getting better. And they highlighted for you what you need here. CHF, respiratory failure, pulmonary edema, and they have back pain. They're not quite sure what the back pain's from, but they do have back pain. 3F, this is another chest x-ray. 3G is a discharge summary. Very, very straightforward. Once it kind of starts flowing, it gets straightforward. Isn't always straightforward. 4A, ENT, ear, nose, and throat consultation. This is inpatient consultation. Make sure you're pulling your codes from the inpatient, not the outpatient. Patient has respiratory failure. They have failed any attempts to be weaned off the ventilator. They're even planning a tracheostomy, which means that they're probably long-term going to be on that vent. They have chronic respiratory failure. 5A, consultation, transfer of care. This is inpatient. Inpatient consultation, the patient has some wheezing. They have a mitral regurgitation, VTAC. Multiple PVCs isn't really going to necessarily matter. A PVC isn't, but I guess if they had a whole string of them, it would start mattering, or start to matter. But VTAC, generalized edema. They're pulling some cardiac meds here, or cardiac labs. I think the patient had some chest pain somewhere, and why I didn't highlight that, I don't know. Yep, pain across his chest. So from a diagnosis standpoint, now remember this is an inpatient consultation geared toward, so this doctor is coming to do a consultation because of the VTAC, the wheezing, the chest pain, and possible pulmonary edema. So anything respiratory or cardiac, this consultation is going to address. So since I don't see an order to have to do here, so I would just do it how the doctor did. Wheezing, your insufficiency, your mitral insufficiency, the VTAC, you've got chest pain, and then you have the edema. I would put the chest pain in front of edema, but it wouldn't really matter. Okay, now we're probably going to be getting into this spirometry and these pulmonary function tests, which can just make a person go crazy. So if I were you, these, when they start giving you the CPT numbers here, and then they talk a little bit about them, this is where I've gotten some of my notes that I have put in there, put in my CPT manual. Go through these and make you some notes, lingo notes, or explaining what it is or what it's testing for so that you can use it better. Real world, you're not going to use these much unless you work for a pulmonologist. Sorry about that. Freaking out. Okay, the board, you'll probably have maybe one question where they stack these. I mean, it's not going to be a do or die, but if you can get a higher level of kind of understanding how to apply them, then that's a good thing. Okay, so here we are, 9.6. This is a pulmonary function study. And how I do these is I kind of put my CPT codes where I see the lingo. So your spirometry lingo, and there's probably 5 places where you see spirometry, that's your 94060. Either pre or post, any of that, that is your spirometry, 94060. Always have your 2.6 modifier because it's actually a respiratory therapist who is performing these in the real world. So the doctor is just interpreting the results. So there's a professional component to this. Your carbon monoxide is going to be your 94729-26, 94729. And then your resistance to airflow, your residual capacities, gas volumes, that kind of lingo, MVV, is your 94727-26. And then from a diagnosing standpoint, this patient has dyspnea, which is like a shortness of breath. They have COPD, I believe, and they have that history of smoking. When they say history of, there's 2 tobacco codes for ICD-10. Well, I guess they technically work for ICD-9 too, but we understood how to use them better. There's 2 codes, and there's been a little bit of a how do we use these. So if the patient is a current smoker and it's relevant, then you're going to code it with the F code, current abuse. If the patient has a history of, then you use the Z code. So I think I finally got that 6 months into using ICD-10. 9.7, A is a desaturation study for somnolence. I always have trouble saying that word, somnolence. 7B is a nocturnal I say the department is polysomnography, but they're doing just a single gram or a single study. 7B, these are not hard, it's just a matter of you getting familiar in the medicine section where you're pulling these codes. 7C, multiple sleep latency study. And here I believe there is, yeah, it says that the patient is sleep deprived. I think you're going to find that sleep deprivation under a Z code, lifestyle, and it'll be a Z code. 8A is a sleep study. Sleep study. This is for daytime tiredness and the obstructive sleep apnea. 9.9, pulmonary function test. Again, I would refer back to a few pages ago and kind of label your different CPT codes within the body, so you're kind of matching a bronchodilator to a 94060, carbon monoxide to a 94729. The closing volume, airway closing volume, is 94727. All of these have a 2.6 modifier. Kind of, these are, if you feel like you don't have these at all, you're probably normal. I'm not a respiratory therapist. I've never worked the specialty of pulmonology. I've nursed plenty of respiratory compromised patients, but I've never worked under a pulmonary service or something like that. So it's in the real world, you just don't encounter these. So don't spend a heck of a lot of time trying to memorize these codes that you're, for the purpose of the board, it may be one question, maybe two questions, multiple choice, that if you're familiar enough or have good enough notes, then you can probably just kind of figure out your own way there. 9B, cardiothoracic consultation. This is outpatient. The patient has an ill-defined mass in the right mid-lung, so that's your diagnosis code. They do talk about the patient having GERD here, but that really doesn't have anything to do with the lung mass. So at first I highlighted this and I thought, I'm going to code this. And then I thought differently, because this consultation is a respiratory consultation. So unless they determined that the respiratory issues were coming from GERD, which they're not going to, because there's a mass, then it's irrelevant. So it's irrelevant. 9C is a lung mass. This is a lobectomy, right upper and right middle lobectomy. This is on the right side. Make sure you have that. And then it ends up telling you that it's cancer. They refer you over here. This is a really kind of pretty good pathology report to me, and I just wanted to show again how, if they do give it to you clear like this, how you interpret the information that you're seeing. This particular pathology report has specimen A, specimen B, and specimen C. So anytime you see the A's, B's, and C's, they're referring to these specific specimens. So this is talking about the gross description of specimen A, B and C, intraoperative, we're done. So that's kind of how you read this. So you're going to have one clear-cut level, and then you're going to have, seems like we ended up, yeah, see, we have the right hilar lymph nodes. We've got 3 lymph nodes, and then we have another. So I got to read here a minute. So there must be 2 hilar lymph nodes from the right. So our lymph, we have 3 lymph nodes here. So that's going to be a level times 3, whatever that level is. Then on B, you have a right upper and middle lobe lung. That's different than your lymph tissue. So you're going to have to level your lung as well. Then you have your intraoperative. And then I think they do 2 specimens intraoperative. Both of these are intraoperative. Both of these, A and B. A little confusing to me. Helped me how I attacked this first is I looked at my diagnosis, because it's very good about telling you numbers. So I knew I had 3 lymph nodes I had to account for and 1 lung. So then I just had to kind of go through here and figure out what was what. So A is a lymph, B is 2 pieces of lymph, C is the lung. Kinda tricky. 9E, this is a critical care or a inpatient consultation note. And how I know it's a consultation, because this will probably kind of stump a couple of you. At the very beginning it says, I have been asked to give an opinion on this patient regarding the blah, blah, blah. So the physician here is saying, I've been asked to render an opinion. That's a consultation. Formal flow of a consultation, a physician, either in writing or in person, but there has to be some kind of documentation, asks for an opinion on probably a certain issue. This happened to be on emphysema. And this patient is intubated. 9F, chest x-ray. I think this is a single view. There are follow-up for the atelectasis. 9G, this is, what did they do? Okay, so read your black here. This doctor who performed the procedure was out of town, so someone else had to cover for him, and explains here how you code for that and how you provide the modifier. So this is a very good example of using that modifier. 9H, another chest x-ray. I believe it's single view. They don't appear to have any pneumonia. 9I, pulmonary function study. Again, this would be considered a pulmonary stress test. Do not get this confused with a cardiac stress test. I actually saw that on one of the tests. Don't confuse this. So this is going to be a walking saturation study, pulmonary stress test for dyspnea or shortness of breath. Here's a discharge summary: adenocarcinoma, atrial fib, and emphysema. Now we get into the nose, a lot of the sinus and the septoplasties and the turbinate reductions, tonsillectomies, that kind of stuff. 10A, this has 3 different CPT codes. They end up doing a septoplasty. They do a turbinate reduction or an excision. Reduction is excision. And a tonsillectomy. And I don't go through here and just memorize everything or read it word for word. I just kind of catch words to make me know they did what they said that they did. So it starts here with the deviated portion of the septum was removed. That's a septoplasty. Then it says attention was then focused on the inferior turbinates, and it goes in to tell you that they were removed. Then they repositioned the patient for the tonsillectomy. So I had proof that all 3 things were being done. Now, modifier-wise, your septoplasty, probably do it first, list it first. Then your turbinate excisions, that was done the right and the left turbinates. So it's going to have a 51 modifier for multiple procedures, same hole, same procedure, and your 50 modifier because it was bilateral. And then your tonsillectomy will have a 51 modifier because it was a multiple procedure, same hole, same incisions, Technically, the tonsillectomy is going through the mouth. I get that. But once you get in the back of the mouth, the top part of those tonsils were being worked on from through the nose. So same type of thing. Now, from a diagnosing standpoint, you've got your deviated septum. You have your bilateral hypertrophy of the turbinates. You have your hypertrophy of the tonsils, and you have your sleep apnea. This number 2, nasal obstruction, that's kind of a symptom of this other stuff, so I wouldn't do anything with that. And I would just sequence my diagnosis codes, kind of how you sequenced your CPT codes. And I see nothing wrong with the order of the procedures that were done, so I would just code it that way. 9/11, thoracentesis. This is the patient has pneumococcal pneumonia and they have COPD. They end up, the thoracentesis, the impression is that pleural effusion. So for this moment in time, I would code the pleural effusion first, then the pneumonia because it's an active process going on that will resolve, and then your COPD because you kind of have it all the time. 9/12, tracheostomy, chronic chronic respiratory failure. They're planning a tracheostomy. That one's not too bad. This is the tracheostomy, so that's what you'll be coding here. It's an op report. 9/13, again, this is your septoplasty with your turbinoplasty with your ethmoidectomy. When you get into this area of the CPT manual, let me grab my CPT and show you. I don't crash everything. Let me get over here. Because you can, once you know what's being done, heck, I'll get there in a minute. I guess I can't read at the top, can I? Once you see what's being done, like you're able to pick out, you have a slew of, so this is on page 176 of the CPT manual, and you start seeing all of these parentheses of stuff. So take what they've done and see if you can plug it into one of these parentheses. These are very, very, very helpful in these endoscopic procedures with the sinuses. This particular one, close to what they did before. They have the hypertrophic ethmoid sinus cells, they have the hypertrophic inferior turbinates, and they have a septal deviation. The reason I would change this sequencing, the last one we did have excisions for those turbinates, but that's a very minute type of excision. So here we're actually removing part of the ethmoid sinuses. That's the big dog procedure, in my opinion. So I would sequence, and again, you're going to have 3 CPT codes. I would sequence the ethmoidectomy first, then the septoplasty, then the turbinate excision. Again, you're going to have your 51 modifiers. Your turbinates are both left and right, so that's a 50 modifier. And make sure you're tracking left and rights. So let's kind of look at the op note and see where we can pull our information out. This is just getting the patient draped and intubated and stuff. So here it says the large anterior ethmoid bulla was taken down, and we went posteriorly into the ethmoid cells and removed a medial portion of the anterior and posterior ethmoid cells. That's your ethmoidectomy. Bulla, conker, bullosa, anytime you see that, usually translates into cyst of wherever it is. The root of the middle turbinate was identified. The turbinate scissors were used to resect. That resect is remove. So that's a removal of the left, was it left? Root of the middle turbinate. The turbinate scissors were used to, yes, that's the left side. We removed the deviated portion of the bony septum, so this is your septoplasty, and they're talking about some work on the tip, I think. Then inferior turbinates were then medialized. These are large and redundant. This is more left. And then the inferior turbinate on the right. So this is your right turbinate. Your diagnosis codes had, you've got your deviated septum, you have your hypertrophy of the turbinates, and you have the hypertrophy of the ethmoid sinuses. That may translate into sinusitis, inflammation of the ethmoid, from a diagnosing standpoint. 914, this is where you're going to see your conker bullosa, which is a cyst. It equals a cyst. This is an ethmoidectomy and antrostomy, ostomy, surgical creation, antro, or this is actually in the maxillary sinuses where they go in and they actually kind of clear out a space. Like if you're walking into a big hotel and you go in the front of the hotel and you look up and the ceiling's way up there and it's just this huge open area. That's what they're doing to the sinuses in an antrostomy. So here we have the maxillary antrostomy that was done, we have the ethmoid excision that was done, and then we have the excision of the conker bullosa. Trying to get that to not, I don't know why it's freaking out. Okay, you can stop now. Okay. Again, you'll need your left. You'll need your left, right or lefts. You'll need your 51 modifiers because it's multiple procedures in the same. Maybe if I put my hands here. There we go. I stopped it, so I guess I got to keep a hand. I always forget that. Diagnosing standpoint, you have your acute sinusitis, and then you have that conker bullosa, which I think you're going to find that by way of cyst. 915, inpatient consultation. This patient has lung cancer. 15B, this is an inpatient subsequent note. Here they can't decide if the cancer, the primary is either of the lung or the esophagus, so you're going to need to find the unknown code for the cancer, unknown, because you can't just pick one. The doctor didn't pick one, we can't pick one. 15C, inpatient. Subsequent, this patient has that lung cancer, has a secondary esophagus cancer, lung to esophagus, so lung is primary, esophagus is secondary, and then they have a pleural effusion as well. 15D, chest x-ray to view. This one has the pleural effusion, has the cancer, and has the COPD. 15E is an EGD, esophagogastroduodenoscopy. They are taking a biopsy and they're dilating the esophagus. So you will have two CPT codes. Your biopsy I would do first, and then I would do the dilation. I would put a 59 modifier on the dilation because it was done for a specific reason, not to aid in the upper GI, but it was done for a definitive medical reason. And then your diagnosis code is going to be that cancer. CT guided lung biopsy here. You're going to have your, you'll have two codes. You'll have your CT needle placement and then your biopsy. Obviously, the biopsy would be coded first. Path report. This is large mass left recurrent. So you're coding for the fluid cytology. So this isn't a true like leveling of a path report. You're doing it for the cytology. Malignant cells suggestive of undifferentiated neoplasm. They're saying that there's cancer, but it's suggestive of a certain type, and that we can't code. So you're going to have to just code a generic lung cancer. 15H, this is ultrasound marking for thoracentesis because of pleural effusion, or that pleural fluid. 15I, this is the thoracentesis. They're doing a 4-quadrant pleural biopsy, so they're going to place the needle 4 times. So you're going to have to take that code times 4, and then needle placement code times 4. And then you'll have your thoracentesis code. I would put a 59 modifier on it, signifying that it is separate and identifiable than those needle placements. And then they have cancer. Here's your cancer. You're leveling in the path report. Here's a oxygen DSAT study. Your chest x-ray. This has a pneumothorax and has, what do they have? Pleural effusion, I guess. So they have pneumothorax and a pleural, oh yeah, right here, pneumothorax and a pleural effusion. If it's a snake, it would have bit me. 15M is a thoracostomy, ostomy, surgical creation, so they're putting in a chest tube here. Thora meaning chest, ostomy, surgical creation. 16A, this is an emergency room report. They do intubate the patient because of lung edema. So you'll have to code that intubation as well. The ER doc did it. 16B, this is an inpatient consultation. Patient is intubated and on the vent. They have had bypass grafts in the back. They are having a heart attack, and they have acute pulmonary edema and acute respiratory failure. Very, very, very sick patient here. They also have chronic renal failure. So there's just a heck of a lot going on. So from a diagnosing standpoint, your MI has to be first. That's the current huge thing going on right now. Then you've got that lung edema. Then you've got your acute respiratory failure. That's why they're intubated. You've got your chronic kidney. You have your intubation, your Z code for intubation. And because this is a cardiac patient who's been bypassed before, I would do the Z code for the presence of the cabbage or bypass grafts. I think it's very pertinent to what's going on. Chest x-ray here, one view. Chest x-ray again. This is still one view. You had several diagnosis codes here, your acute MI, your lung edema, your acute respiratory failure, and then your renal disease. Keep in mind, they're not giving us a stage in this renal disease, so you just use the N18.9. The 0.9, we don't know the stage. 16E, this is acute respiratory failure patient, same patient. Subsequent day in the hospital, and then the discharge. I'm glad he went home. He didn't seem like he was going to get better. So this is your discharge summary from a diagnosing standpoint. Make sure you're getting the subendocardial infarction. That's specifically where it was. You've got your congestive heart failure and your acute respiratory failure. Seems to me like they give us some specifics about that heart failure, that it's a left ventricle failure. But I might, oh, why did I even turn the page? I might be making all that up. Let's see real fast. Okay, so congestive heart failure it is. 917A, bronchoscopy. Now remember on these bronchoscopies, same thing with your EGDs. You can stack them. If they're removing, and colonoscopies, they're all kind of the same. You can stack them. So if they're doing biopsies or removing polyps by several different techniques, then you can stack those. If they use a hot forceps and a snare, then you can code both of those. You can stack them. Okay, so this one ended up being a brushing and a lavage. So there's going to be 2 diagnosis codes that you can use. Cell washings are always bundled in. Always bundled in. You don't code separately for cell washings unless that's all that was done. Then you could, but I believe that's a separate procedure. So, which means it's bundled into everything. Diagnosis standpoint wise, they're on the ventilator. So make sure you have that, and they've had an abnormal chest x-ray. So that's why they're having this. 18A, another bronchoscopy. This one, you've got 4 different CPT codes because they did that many. This is a great example of how you can stack them. So they did a biopsy transbronchial, so that's through the bronchi and just in the bronchi. So you've got biopsy of transbronchial, you have biopsy bronchial with a 51 because multiple procedures. Then you have your brushings, BAL, brushings. Nope, that's your bronchial alveolar lavage. I just lied to you. So that's your 31624. Up here, the top line, multiple biopsies, brushings. There's your brushings. Whoop, glad we got that. So you've got 1, 2, 3, 4 diagnosis codes. You will see if they do multiple biopsies, the same technique, you will see that you have that parentheses S, which means you don't times out your biopsies. Your diagnosis is the bronchial cancer, and they're on a vent. 18B, this is the cytology. There are malignant cells present for the adenocarcinoma. And here they gave it to you, adenocarcinoma, well to be moderately differentiated. So you have not only your cytology cells, you also have your level because you have tissue from the biopsies. Okay? And that is it for respiratory.